Here comes part two, where we focus on the actual non-steroidal anti-inflammatory, the drugs that reduce the inflammation process. This starts on page 119 in your text. And so I want to start with a reminder. I'm going to put this eicosanoid cascade, my little chart, back up here. I want to remind you that we're talking about injury, and then all of a sudden injury releases this arachidonic acid, and phospholipase comes in here and kind of activates it. Then it gets interacted with these enzymes, the COX-1 and COX-2 cyclooxygenase, and then that produces a whole range of prostaglandins and thromboxane as pretty powerful chemical mediators of inflammation that drive our musculoskeletal inflammation process. You can see I've put my little areas of intervention here where we go, look, aspirins and traditional NSAIDs. Aspirin to traditional NSAIDs will inhibit both of these, COX-1 and COX-2, so will limit the formation of prostaglandin. And then you can see this right here. There's a class of drugs, of anti-inflammatory drugs that are trying to be specific to just the COX-2. And that sounds like a good idea, and you'll see that, but it's a little bit harder to do in practice. As a spoiler alert, yes, you can. We do have steroid anti-inflammatories that interrupt this process way up here before it even gets to this arachidonic acid concept. Anyway, but as we continue to go through here, the first drug that we talk about is aspirin, which is a salicylate, and there's a whole family of salicylates that we're going to talk about. We're going to hone in and focus on just salicylic acid, which is our aspirin. There's, like I said, there's other ones like the topical analgesics have some salicylate in it, methyl salicylate. We're focusing on the actual aspirin itself. And really, aspirin has a lot of pretty powerful effects. And I start with the effect outside of that inflammatory cascade, right? This has nothing to do with inflammation. This goes right to the brain and has an analgesic effect, a central analgesic effect. So aspirin is a kind of a weak analgesic, but it does a pretty good job. When we get into that eicosanoid cascade, the aspirin will inhibit both COX-1 and COX-2. COX-1 has those effects throughout the body, specifically in the uterine and GI tract. COX-2 is responsible for creating some of those prostaglandins that are specific to the inflammatory process in those tissues, soft tissue kind of thing. But aspirin doesn't discriminate. It inhibits both or all different types of this cyclooxygenase, which is COX-1 and COX-2. It will also interrupt, you can see the bradykinin, the whole complement system of plasma protein response. So it's going to inhibit that from an inflammatory process. It also is again, we jump back outside of that eicosanoid or inflammatory process to affect the brain and have a fever reducing component to it. So an antipyretic, when you see something as an antipyretic, it's a fever reducer, and it acts within the brain to actually reduce the temperature, and you can see that there's a mechanism that's associated with that. On the inflammatory side, here's just another kind of a schematic diagram of that eicosanoid pathway or cascade as it comes down here. Prostaglandins, what I want you to focus on here is the aspirin inhibits all prostaglandin synthesis, all those different types. I'm going to throw thromboxane in there. It's a very powerful inhibitor to cyclooxygenase. So it stops everything right here at this branch, and so none of this bottom stuff can go on or can happen. And so that's a good thing if we want to limit our inflammation. So if you don't want deviled eggs, if you don't like deviled eggs, just go break all the eggs, right? And then you won't have them. And so that's kind of what the aspirin here is doing. All right, so the irritation of that GI tract is specifically related to the inhibition of COX-1 and those prostaglandins that the COX-1 enzyme is going to kind of create, which is the protective actions of decreasing stomach acid, increasing stomach mucus, and protective, protective fluid. So yeah, that's why we talk about we want people to take things with food, or take them before. Make sure you eat first, so we have some protection going on, because we know those prostaglandins are going to get inhibited. I can't, if we inhibit that whole eicosanoid cascade, we're not getting thromboxane. So this is where we're going to get some of those anti-clotting effects of aspirin. So aspirin definitely is an inhibitor to the clotting mechanism that goes on within our blood cells. That may be a good thing, especially if you're a heart patient, right? If you've had a heart attack, or you're a cardiovascular disease and you're worried about clots forming and then breaking off and getting into smaller arteries and causing problems, that may be a good thing. And so that's an application that may be an indication for using things like aspirin. When you talk about, because aspirin has so many different actions and things that it will do, there's a lot of indications that it can be used for. It's a very powerful anti-inflammatory, pain reliever, fever reducer, all these kind of things. There's a lot of things that it does a really effective job, but there's a downside. When something's really effective, there's got to be a bad side to it. And one of them is, there's a couple of different things. First off, there seems to be a decent amount of the population that takes aspirin that can be allergic to it. So just a simple hypersensitivity can be a problem, and that's, you can see some of the classic anaphylactic type things. Yeah, life-threatening, can be life-threatening right here. I do want to focus on this Reyes syndrome as well. Your book mentions that on page 122. There's a little gray box that talks about what it is, and ultimately, in children under 18, basically kids under 18, tend to be at a little bit higher risk for this syndrome with aspirin. There's not a lot of good data, but it's the risk is enough to go ahead and make that as a precaution. And so, because there's other things that are available to kids under 18 to reduce inflammation, to reduce fever, that kind of stuff, ibuprofen, Tylenol are fine. And so we just don't need to go to the aspirin area because we have other drugs that'll do it. And so don't even worry about the Reyes syndrome. Right above that little gray box on page 122, it talks about Reyes syndrome and kind of gives you an idea of what it is and what it would look like in a patient that was kind of having some of that kind of stuff. And hopefully we don't want to get to those. So if we know we're allergic, then let's stay away from those things. I'm going to throw Tylenol in here, acetaminophen, because it's often used as that aspirin substitute. It's often included as a pain reliever, antipyretic drug. It does not have any inflammatory components to it. So that's the biggest thing I want you to note about Tylenol, acetaminophen, because a lot of times we use ibuprofen and Tylenol. We kind of sometimes will alternate them. Which one do we want to get? Do we want Tylenol? Do I want to take Tylenol? Do I want to take ibuprofen? Here's the biggest thing I want you to know about the differences between those is right here. Acetaminophen or Tylenol, there's no inflammatory effect on that eicosanoid cascade. This is strictly a fever reducer and pain reliever. That's it. So we're looking at no effect on prostaglandin production, which is going to cause inflammation. So please know that. It does do well. It acts on the hypothalamus for the pain and antipyresis effects. So make sure that you have and it's a good substitute for aspirin in kids and those kind of things. So make sure you have an idea. Very few, but this may happen in all drugs. You may have some hypersensitivity issues and allergic issues if we have. All right, now we get into the final area, which is our traditional non-steroidal anti-inflammatory drugs. I don't count aspirin in there because it has such wide-ranging effects. I'm going to focus on the NSAIDs like ibuprofen as our over-the-counter, Aleve as our over-the-counter, right? So as a reminder, we get back to this. Prostaglandins are the main driver chemically of our inflammatory process. So if we can limit those, we can limit the effect of inflammation. So by doing that, by limiting the prostaglandin synthesis, we're going to inhibit COX-1, COX-2. Not a lot of prostaglandins are getting produced. We can hopefully stabilize the cell membranes and make them a little bit more or less permeable. I mentioned earlier that there's a class of drugs that try to go, all right, let's just inhibit the COX-2 because that's the inflammatory side. Cool, we've already said that. If we can not inhibit the COX-1 prostaglandins, because we need those in the stomach, we need those elsewhere in the body. Let's just do the COX-2. That's a great idea, man. And we got there. But there's some pretty significant adverse effects that could happen. So we're back here at this point again. Reminder that COX-1 is specifically in that GI tract and platelets. COX-2 is that side of inflammation, and so we're trying to. The effort was to try to harness the good, block out the bad kind of stuff, and that's a great idea. We can dance around, do the bull dance, but there's a lot of side effects that came along with that. We'll talk about that. You'll see that in the specific drugs. Your book does talk about the absorption and process and dosage and going through their adverse effects. There's pretty significant amounts of information in there. I gave you some basic bullet points as we go through, just kind of some general stuff here. And so as we go through the rest of it, the indications are pretty straightforward, right? A lot of inflammatory conditions, pain, inflammatory conditions, and fever. There can be some adverse effects, especially if we're taking some of these COX-1 and COX-2 inhibitors. Some people have sensitivity to these as well, and then we'll look at some of the significant adverse effects and allergy and hypersensitivity issues. All right, I'll finish up there with a fun picture. That's not my cat. And then all of these, what I'm going to do is finish with your list of drugs. So these, when we start the Common Meds notebook, these are the drugs that you are responsible for in this category of anti-inflammatory medicines. So yeah, I'm going to put aspirin in there. Here's your Tylenol. This is Aleve. If you didn't know, you'll know that. This is ibuprofen or Motrin. And then we get to, some of these meloxicam, celecoxib. These are COX-2 inhibitors, Toradol and Indocin. I can't give you every single, I could, but I'm not going to give you every single anti-inflammatory medicine that's out there, but just enough to kind of give you an idea of the different medicines that are out there. That's how I'm not going to go over the specific medicines in the lectures. Your book talks about them. You can read that in there, and so you can see my funny picture, hopefully funny picture of the signs. All right, I don't know if this is a real. I have a lot of these little billboard signs that are kind of funny and cute, but I kind of don't know if they're real or not, but if they were, it'd be kind of fun. All right, I'm done.